All right, great, thank you. So thank you so much for the opportunity to present today. It's very fun. It's 10 o'clock in New York, so there's a little bit of a time difference, but our clocks recently changed. So fortunately, I managed to do this on time. So as mentioned, I'm an assistant professor in endocrinology at Mount Sinai Hospital in New York. And what I'm going to talk to you about today is cancer treatments and how they contribute and affect diabetes. So oncology is a very exciting field at the moment. What's really happening is there's an evolution of these targeted therapies, and they're being more and more approved. So now what happens is you get your biopsy or the tumor is removed. And while there was traditional histology, now there's more and more molecular markers are being sought after. And these molecular markers lead to the identification of various targets. And then there's targeted therapies that are given to treat specific cancers that have specific mutations that can be identified. The thing about this is that you give the medication to treat the target, which is based on this molecular biology, and ultimately it treats the cancer, and then you treat the patient. But what wasn't really initially thought about, which obviously makes a lot of sense if you're an endocrinologist, but when you're treating the target in the cancer cell is not alone in the body. So this was, I took from Google a couple of years ago now, but I thought it was kind of illustrated the point. So essentially you have a cancer cell, but when you give these drugs, even though they're targeting the cancer cell, they also end up targeting the muscle and the liver and your beta cells and your adipose tissue and the gut and even the brain. And so when we're giving these therapies, it's not surprising that they're going to have systemic effects, even though they are technically targeted therapies. So the outline of the talk is really going to be about what targeted therapies are being used to treat cancer. Obviously, with the limited time, I'm only going to focus on a couple of things just for illustration purposes. The second thing is what are the metabolic effects of these drugs, and then what are the treatment options? So how can we prevent the hyperglycemia and diabetes when people are getting these targeted therapies? So the aim is really just to give you an overview of a taste of some of the new cancer therapies that are coming out and their metabolic effects. To discuss their pathophysiology of how they develop, how they cause hyperglycemia and diabetes, and to examine some of what we know and what we don't know with regard to treating these people and how to best treat the diabetes. So why am I talking to you? So I have a European connection, so I'm actually from Dublin. This is just the map to show you, and I trained grew up in Dublin. I went to medical school in Dublin. And I trained in the Mater Hospital, and this is just a picture of the Mater Hospital in Dublin, which is the old face of the original hospital building. I then moved to New York with the plan of initially basically doing basic science research. I thought I would train here for a few years and then return to Dublin. And so now I'm basically here at Mount Sinai, and I've been here for a number of years. This is literally where I am right now. This is Mount Sinai Hospital. This is Central Park. If you could, I'm literally sitting in this building around here, and if you could see through the wall behind me, you would see Central Park is right behind me. And so what I do here now is essentially a mixture of things, and it's a very exciting and fascinating job that I have. So I spend most of my time doing research, mostly basic science research in animals, looking at the links between diabetes and cancer, and how hyperinsulinemia and insulin resistance contributes to different cancers. I'm also a clinical endocrinologist, and so my own practice is basically an onco-endocrinology practice. So on Fridays, I see patients, all from the oncology services, all who have some sort of endocrine or metabolic consequence of their cancer therapy. And then I also I'm involved in teaching of our internal medicine residents too, and how I'm basically inspiring them to hopefully become future physician scientists. So back to the talk. So essentially, what I'll talk about again is basically start with these targeted therapies and which ones are being used to treat cancer. So the two that I'm going to focus on today are really these receptor tyrosine kinases and the Pi3 kinase AKT mTOR inhibitor pathway. And the second is the immune checkpoint inhibitors. And really, these are to illustrate many of the factors that contribute to hyperglycemia and the developing areas in cancer. I know you have another talk on glucocorticoids in cancer, and these are the other treatments that all contribute to potential metabolic effects in patients who have cancer. But as I said, just for in the interest of time, I'm really going to just focus on these two specific groups. So we'll start with the immune checkpoint inhibitors. This is a rapidly evolving area, and I'm not an immunologist, but this is essentially my kind of basic understanding of how these drugs work. So what you're trying to do, so basically when you have a cancer cell, often the cancer cell will cause immunosuppression. And this basically means that the T cells are not attacking the cancer cells, and this immunosuppression in the tumor microenvironment allows the cancer cells to grow. And so there are two steps in this sort of T cell effector phase where the T cells will attack the cancer cells. And the first one is what's called the priming phase, and the second then is the effector phase. So the important molecules that are important for the purposes of this presentation are the CTLA4 and PD1, PDL1. So CTLA4 is essentially a receptor for this thing called B7. And so when you have CTLA4 interacting with B7, it basically dampens down this effector phase, so the T cells do not get primed. When you, in the effector phase, the two important molecules are PD1, which is the receptor, and PDL1, which is the ligand. And when these two interact, you basically have a dampening down of the effector phase. So the drugs that have been developed are essentially monoclonal antibodies that target CTLA4 and therefore inhibit the interaction of CTLA4 with B7. Or secondly, they either target PDL1, so therefore inhibiting the ligand, or they inhibit PD1, which is inhibiting the receptor and therefore preventing this interaction between PD1 and PDL1. In current treatment, there are strategies where you basically combine these two things together. So you can give the monoclonal antibody against CTLA4 with the monoclonal antibody against PD1. And this is important just because it can increase the efficacy from the cancer perspective, but can also increase the side effects. So this is like the US perspective on this. This is from 2018, and basically this is all the different types of cancer that had an FDA approval for the use of these immune checkpoint inhibitors. And I'm not going to go through them all, but basically the point of this is that there's an ever increasing number of cancers that are being treated with immune checkpoint inhibitors. And so it's important, and you will come across these in clinical practice just because of the amount of people being now treated with these therapies. So as well as having anti-cancer effects, they also have a number of other immune related adverse events. And from the endocrine perspective, the most common side effects are basically thyroid disease, pituitary disease, adrenal, and diseases affecting the pancreas. And these are all basically autoimmune responses that lead to inflammation and endocrine organ dysfunction. So from the diabetes perspective, this now came out in 2016, and it's just, it was highlighted in a lot of the lay press, including the New York Times, after it emerged that people who were treated with these immune checkpoint inhibitors could develop type 1 diabetes. And the feeling at the time, as this patient is quoted as saying, it's sort of the feeling was that people had metastatic cancer that was potentially lethal. And therefore, if these drugs caused other side effects, even if they caused type 1 diabetes, people felt like they could deal with the type 1 diabetes if they could beat the cancer. And this is one of those original case series, and it's just to really illustrate the point of how this autoimmune type 1 diabetes presents. And so I apologize, these numbers are in the US units. The conversion from glucose from milligrams per deciliter to millimoles is to divide this by 18, but essentially the glucose numbers here are in the range of more than 20 to up to like about 40 millimoles. And so the patients are atypical for type 1 diabetes in that they are older, and that's just basically based on the age at which these people are being treated for metastatic cancers. You'll notice here, so this is one of the interesting things, that the drugs that seem to cause type 1 diabetes are mostly the PD1 targeting therapy. So these ones that affected that right-hand side of the picture, the effector phase. So nivolumab is one of those PD-1 anti-PD-1 monoclonal antibodies, and pembrolizumab is also targeting PD-1. So most of the studies have actually shown that it's really the PD-1 monoclonal antibodies that are associated with type 1 diabetes or autoimmune diabetes, depending on how you want to define it. And essentially, the CTLA4 inhibitors are almost never associated with the development of type 1 diabetes, although there are 1 or 2 case reports. The C-peptide levels are usually low, and if you check them on repeated measurements, they usually become undetectable over time, even if they're initially detectable when the patient first presents. The time after the patient starts the anti-PD-1 therapy is usually quite quick. So it's usually within the first 3 to 6 months, and that's typical for almost all of the immune-related side effects of these immune checkpoint inhibitors. And then what's interesting is it's about 1/3 of people, 2/3 of people will have immune-related autoantibodies. And so GAD65 is the most common one that people will have when they develop type 1 diabetes. And then the other interesting thing is it's more common in people who have these HLA phenotypes that are associated with type 1 diabetes anyway. So this was one of the original case series of just 5 people, but really it has transpired that this was sort of representative of who does develop type 1 diabetes, and it really is representative of the picture and how they develop type 1 diabetes. So from the clinical trials, it's still rare. So even though we do see people on these drugs who are developing insulin deficient diabetes, it is less than 1% in most case series. When you combine one of the PD-1 inhibitors, nivolumab, with the CTLA4 inhibitor, ipilimumab, it does increase to slightly more than 1%, but it's still very low. And there's really no great prediction of who's going to develop autoimmune diabetes with these drugs. You really just have to monitor for signs and symptoms of hyperglycemia, which usually develop very rapidly if it's going to happen. So what has also been interesting and what's emerging is that there's probably more to the picture than this, simply this insulin deficient diabetes. And this I put together based on a study that we did here with Amanda Leiter, who's one of our now faculty, who was a fellow at the time when she did this study. And also there's a group in Germany and also in Italy who've been sort of putting together, between cases and case series and small retrospective studies, there seems to be basically a bigger spectrum to the hyperglycemia. So one of the things is that because of the number of immune-related adverse events in other organs, such as like the liver and the lungs, a lot of people who get these drugs are also treated with glucocorticoids. And in actual fact, this is the most common cause of hyperglycemia in people on immune checkpoint inhibitors. And then there are this small number of people, as I said, like less than 1%, who develop this autoimmune type 1 diabetes type picture, which is basically autoantibody positive in most cases and C-peptide deficient. There are some people who can get a transient hyperglycemia related to pancreatitis. There are these interesting cases now of lipodystrophy, which causes a severe insulin resistance. And these are case reports that are coming out, but there are a number of them now, not a number, a few of them that have been published, where patients basically develop this lipodystrophy, fatty liver, and severe insulin resistance. And then there seems to be this sort of, again, now described, but sort of not very well understood, transient worsening of type 2 diabetes after people start the immune checkpoint inhibitors, which then improves again after a few months. And so we're still learning basically about the full spectrum of hyperglycemia associated with immune checkpoint inhibitors, but it seems to be very interesting and far more than simply the immune deficient type 1 diabetes. But how does this, so the autoimmune type diabetes is basically the classical presentation. And so classically what happens is presents as a sudden onset of severe symptomatic hyperglycemia. So the people are usually have fairly normal blood sugar, then you notice it's kind of crept up to 200, and the next thing it's crept up to 800 or about 40 millimoles on the blood sugar. And the patients develop all the symptoms of sudden onset of hyperglycemia with polyuria and polydipsia, and frequently end up in the emergency department. It's almost always with anti-PD-1 monoclonal antibodies, and very, very rarely with the anti-CTLA4 monoclonal antibodies. As I said, about 2/3 of people will have positive autoantibodies, most commonly have GAD. And the treatment is really the same as long-term treatment for type 1 diabetes. The only caveat being that it can be complicated, of course, by cancer progression and other therapies. So sometimes, unfortunately, just because you develop autoimmune diabetes secondary to the immune checkpoint inhibitor does not mean that you're going to actually have a cancer response to the immune checkpoint inhibitor. And therefore, people with new onset type 1 diabetes can end up then going on to other cancer therapies that can be complicated to manage. And it may be under-recognized also because people have pre-existing type 2 diabetes. So in the US, over the age of 65, about 20 to 25% of people will have type 2 diabetes. And so in this population, you may have an exacerbation of hyperglycemia that's not really very well understood or not well recognized as being type 1 diabetes. The patient just starts getting treated with insulin, and it's not recognized that it's really related to beta cell destruction. And as I said, there's an emerging spectrum of hyperglycemia in these people treated with immune checkpoint inhibitors. So the second thing I'm going to go on to then is these receptor tyrosine kinases and the Pi3 kinase, AKT, mTOR inhibitors. And personally, I find these very interesting just because I really like insulin signaling and insulin receptor signaling pathways. And these make so much sense to me as regards why they cause changes in blood sugar levels. And I think they're very interesting just from a physiological perspective. So one of the reasons I got so I came to New York, as I said, with kind of an idea that I would do research. I was thinking for a few years, and I didn't really realize how much I would enjoy it, and how much you learn from it, and how much you really take from the basic science and can actually bring it back to the clinic again. And so it's always amazing to me that people don't really understand how insulin causes the blood sugar to go down. And so for anybody who's not very familiar, the insulin, when you give somebody insulin or when your pancreas makes insulin, it binds to the insulin receptor. And the insulin receptor is, as I'll show you, part of a family of receptor tyrosine kinases. And what that means is just that they have the kinase enzyme as part of the receptor. And this gets activated by phosphorylation, which leads to what's known as the signaling cascade. And essentially the main players that I'm going to talk about today in this cascade are Pi3 kinase and mTOR. And so in order for insulin to cause glucose uptake, you have to activate this pathway. And so you cause activation of Pi3 kinase, and this essentially through a few other steps cause GLUT4, the glucose transporter 4, to move to the cell membrane in, for example, adipose tissue and muscle, and this causes glucose uptake. And there are other effects of this also. So you'll see Pi3 kinase is essentially a major step in this pathway that then leads to these other branches. And these lead to glycogen synthesis in the liver and also protein synthesis in, for example, muscle. And this is why insulin is like a metabolic hormone that controls protein synthesis, also controls glucose uptake. So the insulin receptor is basically, as I said, part of this tyrosine kinase family of receptors. And there are a number of other receptors, notably EGF receptor, and this is part of the HER2 family, which is often mutated in cancer. And also like VEGF, which is also one of the main receptors that can be activated in cancer. And the importance of this is really that from the cancer perspective, a number of drugs are now available that target these specific receptor tyrosine kinases. And the thing is, they're all very similar. And so because the kinase activation part of all of these receptors is so similar, often the drugs, even though they're targeted to one specific tyrosine kinase receptor, so for example, it might be targeted to EGF receptor, but they often have off-target effects that contribute to some inhibition of the other receptors. And again, this is, I don't expect you to know all of these drugs, but a lot of these drugs that are all INHBs are small molecule inhibitors of tyrosine kinase receptors. And so this is just to give you a taste of how many of these drugs are now, these are all FDA approved in the US for the treatment of different cancers. And so this is just to give you a taste of, again, this expanding field of targeted therapies in cancer and how they can contribute to differences in glycemia between either causing hyper or hypoglycemia. So the next step in the pathway, as I said, is Pi3 kinase. And we also have a few drugs that are now approved to inhibit Pi3 kinase in cancer. Pi3 kinase is one of the most frequently mutated proteins or genes in different cancers, such as breast cancer. And therefore, a number of drugs have been developed in order to target this specific protein. And then mTOR inhibitors are also in current clinical use, for example, for some of the neuroendocrine tumors and also for hepatocellular carcinoma. So one of the reasons I really was excited about this is when I started first in the lab, I joined Derek Leroy's lab when I moved here. And the very first experiment I ever did was an animal experiment when I got used to handling mice. And so we basically were testing Pi3 kinase inhibitors in this mouse model of hyperinsulinemia. So we had basically wild type mice, and this MKR mouse model is essentially a mouse model of pre-diabetes with hyperinsulinemia. And so what we found was that when the tumors, we could inhibit the tumors in the mice by inhibiting Pi3 kinase, but also what we found was happening was the mice were developing hyperglycemia and hyperinsulinemia. So this just basically shows you the Pi3 kinase inhibitor treated wild type mice. After 2 weeks of treatment, their blood sugar went up to over 15 millimoles. The pre-diabetic mice that started off with higher insulin levels anyway developed more severe hyperglycemia, and the insulin resistance was severe again, with severe hyperinsulinemia developing more so in the pre-diabetic mice than in the wild type mice. This is a glucose tolerance test similar to what you do with people. Basically, the mice were given glucose at time 0, and then we monitor the blood sugar. And what you can see is that the mice treated with this BKM compound, which is the Pi3 kinase inhibitor, developed severe hyperglycemia. And then also, interestingly, they developed hypertriglyceridemia, particularly in the mice that were already pre-diabetic. And so this was fascinating to me because in mice, I did this in, as I said, when I was a fellow here, it's the first experiment I had done. And I thought this was what really made me enjoy basic science, was because you could actually take the tissues out, like the liver. You could see the Pi3 kinase inhibition at a protein level, and then you could actually see the metabolic effects in the entire animal. And so I was more than excited and curious to know what would happen in people. And so this drug is a Pi3 kinase alpha inhibitor, was approved by the FDA in 2019. And the first time a patient was sent to me before they even started the medication was by one of the oncologists, because there were these questions of whether the patient would develop hyperglycemia. And so when the patient came to me, she wasn't diabetic. Her A1C was normal. And so in order to try and figure out what was going to happen, we basically put a continuous glucose monitor on her for the first 2 weeks of her treatment, because we weren't too sure if she was going to develop hyperglycemia or not. And so you can see basically at baseline, her blood sugar was actually normal on average. But then over the 2-week course where she started to get treated with this Pi3 kinase inhibitor, she developed progressive hyperglycemia. The summary is here, and although it's probably too small for you to see, essentially she would take the medication every night at 6 o'clock. And you can see that when she would take the Pi3 kinase inhibitor, her blood sugar increased overnight, and then actually sort of improved again as the day went on. And so it was really the first kind of 12 hours of her taking the medication, her blood sugar went up, and then it would sort of decline again. And this is important just for kind of to know this pattern based on the timing of the drug, in order to be able to treat it. So the mechanism makes sense. As I said, it's, if Pi3 kinase is this hub between the insulin receptor and glucose uptake, it makes sense that in adipose tissue, if you inhibit Pi3 kinase, that you're going to decrease glucose uptake. And then what I didn't mention in fat, also insulin, as we know, can make people put on weight because it causes lipogenesis. And so if you inhibit the insulin receptor signaling pathway, you get lipolysis, which is probably why the people develop, or why, at least why the mice developed hypertriglyceridemia. In the liver, you get increased glucose output through increased gluconeogenesis and glycogenolysis when you inhibit Pi3 kinase. And so this is why you get this severe insulin resistance, because basically the drug is blocking insulin receptor signaling. So the blood glucose goes up, and then you have to compensate, so you can see the insulin levels increase to compensate for the severe insulin resistance. From the cancer perspective, this, of course, is how the drug inhibits tumor growth and survival. And what's been interesting is there are some recent studies that suggest when you actually cause the severe insulin resistance and the hyperinsulinemia, at least in preclinical studies, there's a suggestion that you may actually then overcome the inhibition with the Pi3 kinase and actually reactivate the pathway. And this could potentially lead to treatment resistance from the cancer perspective. So the treatment options for these for this hyperglycemia, why is it important? So a lot of the time people don't know why we're treating hyperglycemia. We're not treating to targets. We're not trying to prevent 20-year, retinopathy in 20 years from now, or kidney disease, but there's really a significant morbidity and mortality from hyperglycemia. So the aim is to keep people out of the hospital and to stop them from being symptomatic from hyperglycemia. Patients now talk online, at least the US patients are on social media a lot, and they talk to each other. And so sometimes they don't really want to go on treatment that's going to cause them significant side effects, or they're at least very reluctant to start on these treatments. Sometimes if the patients develop hyperglycemia, you have to stop their cancer treatment. And obviously that's very stressful for the patient and not ideal for treating their cancers. And then, people are living for longer. So cancer is now much more of a chronic disease. And so potentially there are longer term metabolic consequences that we should be treating. So people may not be dying of the cancer if we can help them to survive long enough, but they may end up dying of cardiovascular disease at the end and surviving their cancer. And then, as I said, there's this question from preclinical studies about whether by developing diabetes, you can actually cause resistance to the targeted therapy. So how do you treat this? So if you're developing a severe insulin resistance, one of the challenges is how exactly you treat it. And this is, as I said, this is part of the knowns and the unknowns, in that we know kind of the mechanism involved, but then it becomes a challenge on how exactly you treat it. So one thing is carb restricted diets. And so one of the things is just to try and reduce the burden of glucose so that you're kind of reducing this insulin resistance. And some people are proposing ketogenic diets might be the way to go, although this is still relatively controversial. So one thing is obviously diet will help to control the blood sugar to a point. Insulin sensitizers are sort of the next line. And so metformin and TZDs do work to a certain extent in people on these medications. It's a question of whether SGLT2 inhibitors will work. And again, in preclinical studies, there's a suggestion that these can definitely help to improve the glucose and potentially prevent this, overcoming the block or overcoming the insulin resistance and hyperinsulinemia contributing to tumor growth. Although there are case reports of DKA in people on combination of SGLT2 inhibitors and Pi3 kinase inhibitors. And then the question of insulin. So traditionally, we've been, if you have somebody whose blood sugar is severely elevated, then the obvious treatment is insulin to bring it down. But the problem is that people are not insulin deficient in this situation. They have very, very high insulin levels if you measure them. And so the point of adding insulin on top or treating them with insulin secretagogues that will increase their insulin level further when you're really just blocking the effect of insulin is questionable. And then if they do develop hypertriglyceridemia, how aggressively should we be treating the dyslipidemias of these people for their long-term cardiovascular benefit? So as I said, most of these are question marks because we really don't actually have all the answers to these questions. But essentially, it's an evolving area, and I hope I've kind of given you a taste of, the overall picture of the challenges and the new things that are coming along in cancer that are going to affect metabolism and diabetes. So to conclude, there are many emerging targeted therapies with metabolic adverse events. Improved awareness amongst endocrinologists of which drugs these are and how they can contribute to hyperglycemia and the associated morbidity or mortality will definitely help to either prevent or to improve treatments for patients who are getting these agents. And we really need further investigation to understand exactly the mechanisms and to optimize the strategies in treating hyperglycemia and diabetes in people who are getting cancer therapies. And so my take-home messages are just to remember with all these cancer therapies that although the tumor is here hidden in the background, and that's really what they were designed to treat, you're actually treating obviously the entire patient and all of their metabolic tissues as well. And then from my perspective, really the basic science and understanding the mechanisms of how these drugs work always help with when I'm thinking about how to strategize to manage the clinical patient who's in front of me. And with that, I'll say thank you again to the organizers and the opportunity to talk, and I'm more than happy to take any questions. And if anybody wants to email me, this is my email address.
Thank you so much, Dr. Gallagher, for a really, really interesting talk. I truly enjoyed that, and I share your like for the insulin signaling pathway. So I think
that's good.
So I think while everyone can write in the chat or just let me know if they have a question, and while people gather that together, I have one question. So we know that exercise is one of the most potent means to manage glycemic control via insulin independent mechanisms, because it upregulates glucose uptake into muscle, but it also enhances insulin sensitivity in the hours after exercise and after training. So are there any evidence either in humans or mice that exercise can be used to manage hyperglycemia with these Pi3 kinase inhibitors?
So that is a very good question. Yeah, I mean, there are, not that I'm aware of, actually, I don't know that there are studies in either humans or mice that have looked at that specifically. I mean, it's definitely a good thought, and I don't have, you know, anecdotally, it's like I usually do tell people if they're, you know, if they're kind of fit and able to do exercise, that, you know, nothing crazy, but definitely just sort of gentle exercise will help if they're able to do it. It sort of depends on the patient. You know, sometimes people who are getting these, especially the Pi3 kinase inhibitors, they're approved for advanced, you know, breast cancer. And so sometimes people do have bone metastasis and things like that. And so they can be in pain, and it's not always, you know, practical. But I do agree. I mean, it's things like improving the insulin resistance is really the way to go with this. And if people are able to do some exercise, I do feel like it improves as well, you know, the kind of the morbidity from like muscle loss and things like that with cancer. It's so easy. You see people who are admitted to the hospital, and it's so quick that you can lose muscle. But it's very important, I think, to kind of try and maintain it if possible through these treatments, and it'll make people feel better. But I don't have evidence as such, but I agree with you that it's a good strategy potentially.
Okay, thank you. I do have more questions, but I think I'll let other people ask first. So let me see. So Liz from Oklahoma has a question. So Liz, please unmute and yeah.
Hi. Thank you. That was, yeah, I'm in Oklahoma, so I appreciate the struggle with the time change.
Yeah.
I don't know why we do
I'm just
that.
glad it didn't go forward and went backwards, because I would have been an hour late.
Yeah, exactly. So that was a great talk. I'm really excited about everything you said. And one of the things that I work on is breast cancer endocrine therapy. So tamoxifen aromatase inhibitors in mice. So I'm not an MD, I'm a PhD, and I do the kind of preclinical studies. And I actually was going to ask you, but you kind of already answered it. So when obviously you can't tell patients not to take their therapy anymore, and I realize the importance of how the patients talk to each other and kind of spread, you know, the idea that these therapies may have metabolic side effects, and so you can't tell them not to take their drugs because the drugs are obviously very effective for their cancer. So where do you think, as a clinician, the next big thing is going to be? Is it going to be in the interventions, or is this something like the anti-diabetic interventions up front with treatment? Or is this something that, you know, we just need to develop better therapies? And the reason I'm asking is to try to make the most use of some of the preclinical models that I've developed, because we can test interventions, and we've actually done exercise studies in mice. I just need to probably get those out. So yeah, I'm just wondering kind of what your vision is about the clinical or the translational side of things, and what's the important way to prevent these long-term effects or short-term effects even.
I think, I mean, it'd be interesting to talk to you at some point later on as well about your work, but I think there's two things. I mean, with all the hormonal therapies in men and women, you know, there's these long-term metabolic consequences are critical. In prostate cancer, it's probably more obvious even than in breast cancer, in that men frequently aren't dying from the prostate cancer anymore. They actually potentially can die from cardiovascular disease because they're living so much longer, and the androgen deprivation therapy contributes to that whole metabolic phenotype. And I think, I mean, not to stereotype, but sometimes women have been better advocates with breast cancer than men have been with prostate cancer, and I feel, are often undertreated for the metabolic consequences, and they don't seem to necessarily complain about it so much. So I'm always, okay. I mean, that's my impression. I don't know. I feel like it's possibly changing a little bit, and more men are actually kind of educating themselves too about the metabolic consequences of these treatments, and, you know, the options for doing that. So I usually am quite, you know, really try to treat those metabolic things. And actually now the group here, the prostate cancer group, have been sending me people sometimes before they start on therapies to kind of assess their metabolic risk, get them on statins, get them on, you know, metformin, things like that ahead of time, you know, to try and get ahead of it as opposed to chasing after it when it happens. I think, I mean, the challenge with these targeted therapies is that it's I mean, it's fascinating in a way, but it is the challenge of like, you know, if you, sometimes the issue is if the drug is too targeted, then the cancer cells also develop this resistance. So if you hit one particular molecule, then the signaling pathway just bypasses it. And so some of these ones that are a little dirtier, like the tyrosine kinase inhibitors that hit a few, have actually potentially been more effective than the ones that just hit one, because another pathway will sort of take over. And then, of course, unfortunately, these same proteins are in the metabolic signaling pathway and the cancer signaling pathway. And so whether it's better to go further downstream, like whether it's not like hitting the top of the pathway is not wise, and you should like really, we need to search for kind of the downstream effectors is the better way to go, is one thought that we're trying to just kind of, you know, to try and avoid those systemic metabolic side effects. I think like in now, I mean, things are, you know, they do work for cancers. And so I think if we can manage to sort of understand and get ahead of the metabolic side effects, you know, that's probably the way to go in the short term. And then longer term, potentially, as sort of maybe looking for something that's downstream, that's more specific to the cancer, that's not going to affect the tumor cells, or it's not going to affect the metabolism, is maybe the way to go. I think, I mean, the patients, the social media thing sometimes is good because they talk to each other too, you know, and so sometimes my patients will come in with like, you know, I read online, or this has worked for some people, can I try this, or does this work? So they actually kind of give you ideas too, which or give you feedback, you know, based on their own research. So.
A patient is the one, you know, years ago who gave me an idea for that project to look at. She's like, I had all these problems after I took tamoxifen. I mean, it was one person, but yeah, no, they definitely sparked the, you know, growth of the research field for sure.
Yeah.
So,
I think so, and they experiment with themselves sometimes too. Like I had one person who discovered, like every time she ate like carbs, her blood sugar would shoot up. So she just sort of figured out for herself what she could eat and couldn't eat, and managed to treat her own hyperglycemia. So,
well, and I love the continuous glucose monitor study. That's really important. I think that needs to be done a lot more for some of these patients to find out exactly when things are going wrong. That's awesome.
Exactly.
Thank you. I'll email you. I have a lot more questions.
Cool. Thank you.
So I think that we have Louisa who also has a question.
Yes, thank you. Great talk. I really enjoyed it, and I'm an MD and working as an oncologist. So I think it's very interesting what you said, all you said, but also about immunotherapies and the type 2s that get worsening in the hyperglycemia. So I was wondering, do you think that there's some anti-diabetic drugs that are better, that we should use more when they're treated with immunotherapy, and maybe also with Pi3 kinase? It could be interesting if we should have a focus on combining the drugs due to or depending on the anti-cancer treatment. Do you know what I mean?
Yeah, I mean, that is, this, I mean, the immunotherapies are, you know, a whole evolving field, as you know, too. And there's this interesting data about, you know, people who are obese potentially maybe responding better than people who aren't obese. And, you know, it's kind of controversial, but still sort of out there. And so how, you know, we know from research in diabetes that obviously, you know, the immune system plays a huge role in the development of type 2 diabetes and insulin resistance. And so how exactly these immune checkpoint inhibitors are changing, you know, the immune cells in fat or the immune cells in other tissues is fascinating. And so, yeah, I think we don't know, you know, is it like, are people on metformin? Is that a good idea? Should we be giving people who, you know, who have type 2 diabetes and immune checkpoint inhibitors metformin? Will that improve their outcomes? Is there any signal that that might be the bad thing to do? I mean, we just don't know the answers to those questions, but there's so many interesting questions, I think, and trying to optimize things. You know, sometimes we think we're doing the right thing, but we really don't actually know until somebody does the study. So,
no, yeah, that's a lot that needs to be done.
There's a ton of research to be done. Yeah, it's an interesting field, though. Yeah.
Yeah, and also the Pi3 kinase study showed with the glucose, continuous glucose monitoring. I was wondering, why did you put a glucose sensor on that person with a normal, who weren't hyperglycemic at first? Did you have any idea? Are there any people that you're looking at, especially who are more primed to develop hyperglycemia, or?
So, I mean, with the studies, they actually, you know, it was the people who had pre-diabetes that were more likely to develop hyperglycemia. I think the reason I put it on was just because I honestly, well, so I met the person initially when she came to see me, and you know, I kind of was like, you know, it might cause your blood sugar to go high. And the reason I put the monitor on was actually that she had been previously treated with a number of chemotherapies and had bad neuropathy in her fingers. And what I wanted to do was have her check her blood sugar at home. And she was so upset with the idea because her fingers were so sore from the previous chemotherapy that I was like, okay, let me think. And I went to our nurse and she was like, well, we have some samples. And I was like, okay, so let's just do that instead, and it'll make her life easier. And so we can just check, because I didn't know, honestly, you know, if she was going to go high or that kind of thing. So it was sort of a series of events that just, you know, it was sort of more for the patient. Just, I was like, I felt so terrible for her with metastatic cancer, starting a new treatment. She felt awful. Making her stick her fingers just seemed like a terrible thing to do. So we had the monitor, so that's why we put it on her. It wasn't any really great thought of mine. Okay.
So I think we have time for maybe one or two more questions. I can see that Tina in the chat has asked, if you stop the cancer treatment, will the blood glucose normalize? So is this a reversible effect?
Yes, yeah, it is reversible actually. So that particular person had advancement of her her cancer. She stopped and the blood sugar went back to normal again. So it's yeah, it's fairly short acting effect. I don't know, like, if you happen to be on those treatments, it's kind of like steroids potentially. I mean, there's an unknown out there too. Like if you know, theoretically, if you put somebody on steroids and then stop them, the blood sugar goes back to normal. But if you treat somebody for years with steroids, obviously you cause sort of irreversible, you know, metabolic effects. And so potentially if somebody's on this drug for many months or longer than that, then maybe it'll be slower to turn around. But in my experience, it turns around fairly quickly after you stop it.
Okay, so are there any more questions?
I have a quick question if there's time.
Yep.
Erin, I do mostly preclinical work, so definitely not on the clinical side, but I thought that continuous glucose monitor data was really interesting. And I guess my question is, has anybody looked at sort of delaying the time between when you give each dose of the Pi3 kinase inhibitor, or is there a way to develop a Pi3 kinase inhibitor that's a little bit more slow release? Because it looks like if you could get them down a little bit lower, they wouldn't spike up as high. And I know it's an N of 1, so maybe that's unrealistic.
Yeah, I think, I mean, I don't know the answer to that, to be honest. I mean, if you inhibit, I guess the question is, like, if from a cancer perspective, if you're intermittently blocking that pathway and then releasing it again, is that a good idea? Or does that cause some sort of resistance from the tumor perspective? I don't know. In lymphoma, so there's a shorter acting, like copalisib is the shorter acting one that they use for, I think, lymphomas. And that's like an infusion that only lasts a few hours. And so in that situation, they give the infusion, I think it's like once every week or once every couple of weeks. And the blood sugar goes up too. And the kind of wisdom with that is, you know, to be careful not to give these people insulin or sulfonylureas, because it'll wear off so quickly that they'll end up hypo a few hours later if you do that. But yeah, I think, I mean, these are relatively newly approved drugs, so there's probably different strategies and, you know, the timing and all that kind of stuff. I don't know how much like background work they did on, you know, how frequently, I'm sure they did, you know, on the early phase trials about how frequently it could be given for optimal effect and things like that.
Seems like something we could ask, like Liz was saying, we could ask a lot of questions in the animal models to sort of, how do you combine these various therapies to get some like better results for these patients? So.
Yeah, definitely.
Okay, but I think that's all we have time for. So I want to thank you, Dr. Gallagher, for being with us today. I truly enjoyed this talk, and I hope the rest of you did as well.
Thank you. Thanks for the invitation.